this morning is going to be Emily. So Emily is a final year student, graduate at Cardiff University, medical student, and she's completed 3-year degree in medical sciences at the University of South Wales. Special interests include A&E and general medicine, and she's completing an 8-week elective, spending the first half of this in UK-based A&E departments, and then the second half visiting family in Australia. That sounds lovely. So Emily's going to be presenting on the mind-body syndrome and chronic pain. It has a personal journey for Emily over the last 7 years, and it's led Emily to find some work by Dr. John Sarno on the mind-body syndrome, which is a theory that isn't that well known in sort of mainstream medicine. So this presentation is really going to outline the research supporting that theory, diagnostic methods, and any treatment methods that are associated with that. So I'll hand over to Emily, and if Emily shares her screen, and if everybody else can put themselves on mute, that would be fantastic too.
Lovely. Thank you very much, Selena, for the introduction. Can I confirm everyone can see my slides? Fabulous. Well, it's lovely to be here, and I appreciate the opportunity to share this presentation with you all today on the mind-body syndrome. I'd love to be able to ask for a raise of hands, because I'm really curious to know who's seen or heard of this condition before. But I appreciate it's a little difficult to do online. I can't actually see any of you at the moment. But if you like, feel free to drop me a message at the end of the presentation. But if you haven't heard of the mind-body syndrome specifically, you may have heard of some of these other names that also describe the same condition. We have the musculoskeletal mind-body syndrome, TMS, which stands for tension myositis syndrome, which is perhaps the most commonly known name for this condition, and then distraction and psychosomatic syndrome. So as Lena mentioned, chronic pain has been a personal experience of mine for the past 7 years, and I will be using myself as a bit of a case study, so to speak, as I work through the presentation today. So a little bit of background on me. When I was 19, I had a sporting injury playing squash, where I lunged for the ball and felt a sharp pain in both of my hips. And about 2 months after this, I rolled my ankle over in a hole. So I had 2 hips and an ankle out of action, and I ended up in a wheelchair for a couple of months and on crutches for some periods too. I saw 3 different orthopedic consultants, and they all agreed that I tore my glute medius muscles bilaterally. However, 18 months after my injury, I had an MRI scan, and it was completely normal. Now, in the preceding 5 years, I suffered with a lot of pain. I'd gone from being somebody who was incredibly sporty to somebody who couldn't even walk 10 minutes down the road to the local grocery store. And in my search for a cure, I saw countless different physiotherapists, osteopaths, chiropractors, massage therapists, and I even tried hydrotherapy. And unfortunately, just nothing seemed to help with my pain until 2 years ago, I came across an app called Graepel. So this is an app created by pain specialists, all of whom happen to have their own experiences in chronic pain, and all of whom had completely cured themselves using the technique and the education techniques provided by the mind-body syndrome. So on that note, what is the mind-body syndrome? So it theorizes that pain is a physical manifestation of suppressed emotions. So it believes that when negative emotions accumulate in the unconscious mind and threaten to spill into conscious awareness, the brain identifies this as dangerous, so it creates pain as a distraction so that the individual doesn't have to deal with those challenging emotions. So just very briefly, a bit on how pain becomes chronic, and I'm sure everyone's very familiar with this. So first of all, pain is a protective mechanism. It's a danger signal, and it's essential for survival. So if you were to touch your hand on a hot stove, your brain's going to send a signal of pain so that you remove your hand to prevent further injury. Now, the brain is very neuroplastic, and in persistent pain, the central nervous system becomes hypersensitive and overprotective. So it starts sending off danger signals when there isn't even any danger in sight. So it's essentially a false alarm. The alarm is very real because the pain is very real, but there's no danger anywhere to be seen. And this is known as central sensitization. And unfortunately, this process leads to patients experiencing increased pain severity, increased pain frequency, a reduced pain threshold, and they often start experiencing pain in multiple location sites too. Now, there's lots of emotions that can further fuel this process of central sensitization, but I just wanted to pick on one here as an example. So the pain-fear cycle. And when there's a lot of fear and preoccupation around pain, it's essentially putting the brain on high alert and telling the brain there's still danger. The brain continues to create pain, which causes more fear, which causes more pain, and it becomes this vicious cycle that's really difficult to break. Now, interestingly, lots of studies have shown that there are different areas within the brain that are more active and persistent versus acute pain. And the areas that I'm interested in are certain emotional areas, such as the prefrontal cortex, the amygdala, the cingulate gyrus. They all seem to be more active in persistent pain. Now, I dedicated a section of my essay to Dr. John Sarno, and I'd like to do the same here today because he's a gentleman who pioneered the mind-body syndrome, and he specialized in rehabilitative medicine. So he was constantly coming across lots of patients with a variety of chronic pain complaints. However, he became quickly frustrated because very often, when he did imaging studies on patients, they could be completely normal with no underlying pathology. Or if there was an underlying pathology, this might be in a completely unrelated anatomical location to the patient's presenting complaint. And lastly, as have many studies concluded, many patients can have a structural underlying pathology and absolutely experience no pain whatsoever. So what we can conclude from this is that imaging studies cannot accurately predict which patients will and will not experience persistent pain. Now, this is where it gets really interesting because Dr. Sarno started noticing lots of similarities between his chronic pain patients. So first of all, regardless of the patient's presenting complaints, they would be tender upon palpation in multiple areas of their body, and these areas were the same across the majority of chronic pain patients. Patients also had a past medical history of other psychological or other conditions known to have a strong psychological connection, such as irritable bowel syndrome, tension headaches, migraines, or TMJ dysfunction. I happen to have a history of both migraines and TMJ dysfunction. Sadly, a lot of patients also had a history of adverse life events, whether in childhood or adulthood. And patients also seem to share very similar personality traits. Many patients would report temporary pain relief either when they exercised, had a massage, or used warm compresses. And this is something I'll circle back to again shortly. Talked about how emotions were accumulating in the mind, and I just wanted to give you some examples. And specifically, I'm referring to powerful negative emotions, and there's just a list there on the side. So just to recap, when these powerful negative emotions accumulate in the unconscious mind and threaten to spill into conscious awareness, the brain identifies this as dangerous, so it distracts the individual by creating pain so they don't have to deal with those emotions. Conversely, studies have shown that positive emotions can actually reduce pain. Now, it's worth mentioning that all of these emotions that I've mentioned here can be caused by pain itself, just like with that pain-fear cycle I talked about earlier. They can all develop their own vicious cycles and condition the patient to associate pain with these emotions. Just some sources of what might be causing these emotions, and there are, of course, many, but trauma at some point in one's life, and also the self-imposed pressure as a reflection of one's personality, which brings me on to the type T personality traits described by Dr. Sketchter, a former student of Dr. Sarno. And why, at first sight, these look like some pretty nice personality traits. You can imagine the toll it could actually take on the individual. Imagine that pressure of always feeling the need to be perfect, to always say the right thing, to do the right thing, to always be presenting the best version of themselves, and then being very self-critical if they don't meet the form. So this, you can imagine, is exhausting, and then combined with any negative emotions that are bubbling in the unconscious mind can cause a lot of internal psychological conflict. So we've got this psychological conflict going on, but how does this then relate and manifest in the body? So what's the link? And physicians theorize that the link is the autonomic nervous system, which has many key roles, but one of them being its regulation of blood supply. So it has the ability to cause vasoconstriction, which would reduce blood and oxygen supply to a target tissue, and this causes pain. And many studies have proven the link between mild hypoxia and pain. I just wanted to pick out the middle box here. There's two studies that look at the painful muscles of patients with fibromyalgia. And these studies prove that on a microvascular level, there was dysregulation to the microcirculation, so these painful muscles had mild hypoxia. So I'd like to circle back to what I said earlier about how patients would experience temporary pain relief when they had a massage, exercised, or used a warm compress. And the one thing all these three factors have in common is that they improve or increase blood supply to a target tissue, thus resetting or the oxygen supply and dissipating pain, which is interesting. Now, the diagnosis of the mind-body syndrome is very much a clinical one, so it requires a thorough history and examination process. So it's really important to take the time to thoroughly explore the psychosocial aspects of a patient's life. And I want to take this opportunity as well just to emphasize the importance of ruling out genuine underlying serious structural pathology, because we certainly wouldn't want to miss something like metastatic bone disease, of course. I already talked about a few of the points on this list, but I just wanted to pick out two and just give you some examples. So relief with distraction. I've noticed that on ward rounds, I really don't enjoy them because I'm standing there in one position and I know it's a big trigger for my pain. So I know I'm already anticipating pain and I've got a bit of my own pain fear cycle going on there that I haven't conquered yet. But I've noticed that when the consultant asks me to scribe for him, I have no pain whatsoever because I'm distracted. And then just another one to pick out, the timing of symptom onset. It wasn't until I started doing this research that I was encouraged to do a bit of self-reflection. And I realized that the exact same time my pain started, I was actually going through one particularly challenging relationship, one that caused a lot of emotional turmoil and wasn't helped by my personality traits of being a people pleaser and feeling responsible for others. Now, the treatment of the mind-body syndrome has two salient features, and this is education and raising emotional awareness. Now, like me, many patients would have seen a whole host of healthcare specialists in their search for a cure to their pain. And sadly, they may have experienced some skepticism along their way. So it's really important to take the time to sit the patient down and explain that chronic pain is a psychosomatic condition, one which can cause legitimate pain and debilitation, and is further fueled by this process of central sensitization. And hopefully, once they understand that, they might be able to accept that their pain is not due to any physical injury. But acceptance is really challenging for many reasons, and it's something I've struggled with in the past as well. So first of all, from an evolutionary perspective, humans are hardwired to expect physical injury when we experience pain. Secondly, like myself, many patients would have had an expert diagnosis of an underlying structural pathology, so it's hard to overcome that. And lastly, many patients have had pain for such a long time that they have conditioned themselves to experience pain in certain physical positions or when they do certain physical activities. So they've spent all this time constantly reinforcing the belief that there is an underlying structural problem. It's a really hard one to overcome. And just ways that we could possibly tackle this is by providing some counter arguments, so to speak. So trying to get the patient to think differently about their pain. And some of the questions you could ask patients, just to give you a few examples, is perhaps asking the patient, have they noticed if there's any inconsistencies in how their pain presents? So in me, for example, sometimes my left hip hurts, sometimes my right hip hurts, sometimes it radiates down my whole leg, sometimes my feet tingle, but there's absolutely no pattern to it whatsoever, except that I now realize there's often something troubling me emotionally. Another question you could ask patients is, have you noticed if your pain is worse when you're in certain social situations or around certain people? They may find that their pain levels are worse when they're around people that don't believe that they have pain, for example. And just to give one last example, you could ask patients or encourage them to think about instances where their pain was absent despite them engaging in activities that would normally cause pain. So I think back to a period last year. So I was on the family farm and it was harvest time, and we made over 1,000 conventional bales last year. And it was really hard physical labor. And for that entire 2-week period, I had next to no pain. So much so that I ran out of my opioid medication. And for the first time ever, I didn't get a repeat prescription. And I've been off opioids ever since. And on that note it's really important to encourage patients to taper off their analgesics, which can be really daunting at first, and encourage them to engage in fear-inducing activities. I don't mean extreme sports necessarily like I've got here, that's just a personal goal, but encouraging them to do things like having a shower without taking a stool in with them to sit on. And hopefully in time, the more they do that, having that 10-minute shower without a stool, they'll be training their brain that that is not dangerous and it doesn't need to create pain. And then from an raising emotional awareness perspective, we have expressive writing and focused meditation. And I wish I had more time just to emphasize how important these two factors are. But the key to them is encouraging the patient to sit down and take the time to understand what it is they're feeling, and then trying to work out what's causing those emotions to begin with, so taking the time to process them. Now, this is just one example of an article that supports the mind-body treatment program. And this was a case series of 51 patients, all of whom had chronic back pain, but none of them had any underlying structural pathology identified. They were all diagnosed and treated as having the mind-body syndrome. And the results were brilliant. So pain was significantly reduced, medication use was reduced, and activity levels were significantly increased. So in summary, the mind-body syndrome believes that the root cause of persistent pain lies within the emotional mind. So when these powerful negative emotions accumulate in the unconscious mind and threaten subconscious awareness, the brain identifies this as dangerous. It creates pain as a distraction so the individual doesn't have to deal with those challenging emotions. And I'd just like to say that people can be cured from chronic pain, or at least significantly minimize their pain experience using the techniques that I've talked about today. And I'm proof of that. So here on the left is me in 2015, barely able to stand in one position for more than 10 minutes. To 3 months ago, I was on the top of Penavan Mountain, having climbed it with my partner. These are some books I strongly recommend reading. And on the left, here's a curable app that I mentioned at the beginning. And on the right is a great talk by Dr. Howard Schubner, an expert in the subject, and he can perhaps explain it all much better than I have done today. Thank you very much, everyone, for listening, and